Welcome to the Expert Perspective on the great debates and updates in thoracic malignancies. We had this meeting today in New York on July 12th, 2014. I am Ramaswamy Govindan, co-director of the section of the medical oncology at Washington University and expert on lung cancer. Joining me today is Dr. Roy Herbst, the Ensign Professor of Medicine at Yale Cancer Center and a well-known expert in lung cancer. Roy, it's great to have you.
Thank you.
At the meeting, as well as joining here for the expert's perspective. So we had a lively meeting today. We actually had, as you know, 3 sessions. We talked about the updates on some key topics. We debated on some contentious issues, and we are having case-based discussion as well as a part of this meeting. So you actually began the session today discussing some of the recent advances in lung cancer, and I asked you to talk on lung cancer present and future. I was very intrigued about the LungMap trial. Can you tell us a little bit about that?
Sure. So the LungMap Master Protocol is a new paradigm for trying to sort patients to targeted therapy. What I wanted to try to show in my talk was how we've come in the last 20 years from chemotherapy in unselected patients now to using agents in very specific genotypically driven populations. But of course, as you know, finding those patients are hard. If you're looking at a 5% or a 10% mutation rate issue, you're going to have to screen 20 patients to find one or 10 patients to find one. So what the LungMap is it's a public-private partnership, a trial, SWOG 1400, that's now open. Patients are accrued. We actually put someone on at Yale last week who actually will be screened. It's for second-line refractory squamous cell lung cancer, metastatic disease, and we will put patients on one of 5 different arms: FGF receptor inhibitor, PI3 kinase inhibitor, CDK4/6 inhibitor, an HGF c-MET inhibitor, and for the 50% who don't have a marker, we're using immune therapy, which of course we've discussed at the meeting today. Everyone being treated against a control, that being chemotherapy, separate modular arms. So yeah, it was great to be able to tell the group about it. We had some good discussion, so I appreciate it.
Yeah, you know, Roy, I thought the audience, majority of them are community physicians, were actually quite intrigued by this idea, and they really want to participate in this. I was quite encouraged by the enthusiasm I saw in the audience. What do you think?
Oh, I agree. You know, these trials are designed for the community. We want to bring profiling to the community. While it's done, it's not done as much as we would like, which is 100%. Right. It's expensive. It's paid for by this trial, and it's allowing community physicians not only to profile, but then to match those patients to drugs.
When do you expect the study to be widely available for enrollment?
Well, it's through the National Clinical Trials Network. It's already open at about 100 sites as of today, and it's going through IRBs. It went through the central IRB of the NCI, so many places should be able to open it in that way. It's open, in almost every place that I know has expressed interest to open the study, and things take time as they activate. But I expect by 6 months from now, we'll be seeing accrual hopefully on the order of 30 to 50 a month.
And this is absolutely fascinating. And as you know, during that update session this morning, we discussed the role of EGFR TK inhibitors in EGFR mutant patients. And I'm actually intrigued by 3 different pieces of data. One, the role of afatinib in exon 19 deletion. The ASCO 2014 meeting, we saw a presentation that looked at the updated survival data from LUX-Lung 3, LUX-Lung 6 studies. And as you know, in both the studies, the exon 19 population did much better on afatinib than chemotherapy, almost a 10-month improvement to 12-month improvement in overall survival. This is the first time we have seen head-to-head comparison. We have seen the overall survival when we have a head-to-head comparison of EGFR TK inhibitor with chemotherapy. I'd just like to get your perspective on this, and what is your take on that, exon 19 deletion, afatinib, improved survival?
Right, well, we actually know that we already knew that afatinib produced a benefit in exon 19 patients. It's just that had come from an early analysis of the survival data. This is the final survival analysis. And I agree with you. The fact that there's a survival benefit seen in a trial like this, it's the first time that's been seen. And you would expect the exon 19 patients to do a little bit better because you've deleted a piece of DNA. The chance for a reversion is less. So I think it says, we have a very good drug in afatinib and an improved survival in this group of patients, and it certainly would give someone such as myself some thought to use this drug in those patients.
Right. I did an informal polling of the faculty during this meeting, and seemed like people are looking at this data carefully, and few of the faculty speakers said they are using afatinib in the front line. Others are not so sure. They're looking at the data more carefully. But I'm thinking about this exon 19 deletion. I may offer afatinib given the data that we have seen over other agents.
I would agree.
Curious.
I would agree with you. Many would say, well, what about the next generation EGFR inhibitors that are EGFR mutant kinase selective? And yeah, I would say yes, but show me the data. Those are still a bit away, so I think we have to keep our eye on those. But right now, we're looking to bring the best drugs up forward. In fact, at Yale and also through the Southwest Oncology Group, we have another trial, SWOG 1403, that's being led by my colleague Sarah Goldberg with Katie Paletti. And what they're actually doing is afatinib cetuximab combination in the front line. And I think these exon 19 data make us even more excited about this trial, because now we take the drug that has the survival benefit, afatinib, combine it with cetuximab, where we know that's already had, that combination seems to be quite active. I think it's a very, very good thing.
Absolutely. And I was also very surprised by the data from the Japanese study that actually looked at the combination of erlotinib plus bevacizumab compared to erlotinib alone, and that showed a near 7-8 month improvement in progression-free survival. Again, a little bit more benefit in exon 19 deletion than the L858R, but this 8 to 9 month improvement in PFS, progression-free survival, with the addition of bevacizumab in EGFR mutant patients over erlotinib didn't catch my attention. I just want to get your perspective.
Oh, well, I've been working on that combination for nearly a decade. In fact, in our study Beta, where we had bevacizumab, erlotinib versus erlotinib, over 1,000 patients, a large study, we actually did see there were some benefits in the EGFR mutant patients, but the numbers were small, and it was a retrospective analysis.
Right.
So this being the first prospective analysis, granted only phase 2, but clearly these results are extraordinary. Now we're getting to a whole different, paradigm, antiangiogenesis as a way of avoiding resistance because the effect of VEGF, which is upregulated by EGF. But yes, I think this needs further study. And I'm looking forward to see those results in publication.
Right, that's a good point you're making, and there is an ongoing study called ACCRU, which actually is looking at the same combination, bevacizumab plus erlotinib versus erlotinib alone in North America, led by Tom Stinchcombe and Pasiani. So hopefully, if those results hold up, I think this is really very, very interesting. And finally, the most important part in this segment is that the new agents that are coming up, the AstraZeneca compound and the Clovis drug, which have shown activity in the T790M, and we discussed that today in the morning session as well.
Right.
And just your take on that?
It's phenomenal, the fact that now we're designing drugs against the mutations that develop when you treat with the first-line drugs. Darwin taught us that with treatment you're going to develop resistance. Unfortunately, that occurs a median of about 1 year. So I think both these drugs, the one from Clovis, the one from AstraZeneca, have comparable activity, slightly different side effect profiles, as we heard at the meeting. But I think they both have enough activity data that they should go forward to phase 3, and we'll be seeing that. And that's great for patients because now, when someone comes in, they're resistant to the erlotinib, some countries gefitinib, now afatinib. Now we can move them on to something else.
Absolutely fascinating. And we discussed also the issue of how to approach patients with locally advanced non-small cell lung cancer in today's morning session. And unfortunately, we have not really made much progress in this area beyond knowing what not to do. So we now know not to give high-dose radiation treatment. We also do not have any evidence to say that consolidation therapy is of great benefit. There was some discussion this morning and at ASCO last month about the lack of benefit of consolidation therapy in the locally advanced non-small cell lung cancer. So once again, we went around the room, we polled people, and the general feeling is that most of experts do concurrent chemoradiation and slowly moving away from giving any kind of consolidation therapy. Any thoughts on this topic?
No, I would agree. We, as much as we feel that consolidation should make a difference and that you need more than 2 full cycles of chemotherapy, the data have never supported that.
Right.
So I'll still sometimes do it if the patient's strong and doing well, but I think the concurrent chemoradiation is probably good as long as you can do it with good radiation, good tomographic radiation. I think that's good.
I think we reached a plateau here, and so where to go from here? Immunotherapy trials are being designed with PD-L1 checkpoint inhibitors, and also there's a vaccine study with the MUC1 vaccine in the consolidation setting. And then, in the interest of full disclosure, I have to talk about my study here, and the EGFR mutant and the ALK positive patients get induction therapy with erlotinib or crizotinib, and then get concurrent chemoradiation. And that's part of the RTOG Alliance study that's currently ongoing. We have 9 patients so far, and this is a tough group to accrue to because you have to have EGFR mutation or ALK translocation. So hopefully, at least a defined subset of patients will make some improvement.
How many patients are you looking for?
Overall, I think it'll be about close to 200 patients, and but we just opened this a few months ago, so I'm very encouraged by that. Yeah, I'm encouraged by that.
Interesting.
Yeah, and then we talked a little bit about small cell lung cancer, and we don't see much progress. We have to understand more and more about the molecular basis of small cell before we make progress, and unfortunately, it's still quite some way off before we make significant progress here. And then David Spiegel gave a great keynote address on the immunotherapy. You have done a lot of work on immunotherapy. We don't have time to go over everything, but if you can give us some take-home points on checkpoint inhibitors, that'll be great.
Right, I thought David's talk, which of course will be online, is just phenomenal. The way he explored all the agents and put into perspective all the different phase 3 trials and patients treated. We have 2 agents targeting PD-1, nivolumab and pembrolizumab, and then we have 2 agents targeting PD-L1 and PD-L3280 and then the MedImmune product. And they all seem to have about a 20% activity in untreated patients by response rate. Certainly even more benefit than that because of their durability of response and presumably improvement in progression-free survival, though we haven't seen much of those data yet. The prospects of moving things frontline is shown. Other areas of lung cancer therapy, maintenance is all there. The question also is the markers. David brought up some of the marker work, and everyone using a bit of a different marker and how these markers are going to all sort of sort out. I think, this is a very interesting area. I especially was interested in that slide where we showed the adaptive resistance.
Right.
And I think that, we have to remember that markers here, we talked all morning about markers, biomarkers, EGFR. We talked about ALK during the meeting. Now we have a marker that's a moving target. It's adaptive. Interferon made by the T cell actually can upregulate the marker. So it's going to be a challenge, but it's an exciting one. It's nice to have a challenge, isn't it, when you have something that clearly works and you can even make it better. Right. Isn't that what makes what we do so exciting? We
were talking about these dramatic responses seen in some patients, including complete remissions, durable remissions in these things. Clearly about 20% of the patients in unselected group of patients with advanced non-small cell lung cancer seem to benefit from this class of agents. Relatively well tolerated.
No doubt.
And so a lot of research needs to be done here, but I'm very, very excited about this area of research. So that wrapped up our morning session, and then we had actually a very lively discussion about various topics. There was a discussion between David Spiegel and Karen Reckamp about the role of antiangiogenic therapy in the non-small cell lung cancer, and all of us are disappointed. The promise of antiangiogenic therapy hasn't really lived up, but the basic problem is we don't have a good biomarker to select patients who would respond well to antiangiogenic therapy.
I couldn't agree more. Look, we already talked about erlotinib bevacizumab having some benefits, so clearly there are subgroups where these things can benefit more than others, perhaps. I thought the data for ramucizumab was intriguing, almost there, maybe there, depending on who you ask. maybe needing a little bit more of a biomarker.
This is the VEGF-R2 block, yeah.
Exactly, VEGF-R2. And then, of course, there's the small molecule TDI, TKI from Boehringer Ingelheim, which is in clinical study. That's interesting as well. So this field's, it's not thriving, but it's not hurting. It's
dead yet.
If we, and especially, keep in mind that the immune therapy, which is clearly a new paradigm in this disease, targets the microenvironment. Where do VEGF inhibitors and VEGF work? In the tumor microenvironment. I can't help but think that there's going to be a little bit of synergy between these two, perhaps issues with drug delivery. So I would keep a close eye on this field. This is one to watch. I certainly want to I worked in this a great deal many years ago. I'd like to start looking at some of these agents again.
Absolutely. Then we had a nice discussion again, or debate rather, whether to continue erlotinib at the time of disease progression in patients with EGFR mutant disease, when after they have been on erlotinib for a while, when they eventually progress, whether we should continue erlotinib or discontinue erlotinib when we go on to chemotherapy. And I polled the faculty, and again, I got the sense that majority of them actually they discontinue erlotinib at the time of disease progression. I actually continue erlotinib when they switch over to chemotherapy. What do you do?
I would definitely continue it, and that's how I voted, because I wonder who was voting against us.
That is,
maybe we need a recount, because you still have some clones that are sensitive to erlotinib. So I think you keep that on, add chemotherapy, and actually what's going to be next, you're going to add in your next generation EGFR TKI. But I think you run the risk of having a terrible flare if you don't do that.
I'm very intrigued by this. We have done actually the deep sequencing, complete exome sequencing on a number of these patients, and limited sequencing on a more than 30 or 40 samples, pre and post. I've never seen the sensitive clone disappear at the time of resistance. They pick up more additional clones. That's why I think continuing erlotinib at some point makes sense. And fortunately, we can combine it safely with most chemotherapy agents, so it's not been a problem.
We've seen the same thing in our rebiopsy sequencing data.
They never disappear. Actually, they never disappear.
Other things can be added, but the old ones
the founder clone's always there. And then we wrapped up the morning session with this very wonderful discussion between Jeff Oxnard and Suresh Ramalingam about this key practical issue. When patients progress after second and third line therapy, is there a role for cytotoxic agent in third line and beyond? And the Jeff Oxnard argued for some, and Suresh Ramalingam very effectively rebutted and showed the lack of evidence. All of us would agree, and in fact you published a paper long ago, I remember, with the MD Anderson experience of salvage therapy in third line setting, and you reported, if I'm not mistaken, 2 or 3% response rate.
Yeah,
do you remember that
Dr.
paper?
Massarelli, one of our fellows, and it's still referred to. I have mixed feelings. There's very little benefit in unselected patients of chemotherapy, third line or beyond. But then again, you don't want to give up on these patients either. So I would say they should be getting therapy, but they should be getting a molecularly targeted therapy. There should be lung map trials for patients in this group. We should be sequencing, as we do at both of our centers. At Yale now, I have Paul Ader, Pat LaRusso. I'll let them find a good drug in that setting. That's what
Absolutely. So the big message is we should put them on clinical trials when possible and avoid ineffective therapies. And the last part of the debate, last topic, I think is very, very important. And a few years ago, the EORTC study reported at ASCO and eventually published showed that prophylactic cranial radiation was beneficial in a group of patients with extensive stage small cell lung cancer. And that led to the use of PCI in extensive stage small cell lung cancer. I did that for a few times. I did that a few times, and then after that, I actually pulled back. And I am not a big fan of using PCI in extensive stage small cell lung cancer, partly because by the time they finish brain radiation, they end up having systemic disease, and giving chemotherapy becomes a little bit harder after this. And this ASCO, I'm sure you saw the paper from Japan, a nicely done study that showed lack of benefit, if anything, even adverse outcomes with PCI in extensive stage, not limited, extensive stage small cell lung cancer. Do you send your patients to radiation oncologists for PCI in extensive stage?
PCI is not without its toxicity, and cognitive impairments, and we did some studies way back when, and actually many of these patients have pre-existing cognitive impairment because of the disease to begin with. I was shocked actually when the data first showed that extensive disease patients have a benefit, because it didn't make a lot of sense to me. And I think what we're seeing is maybe it was maybe it's not as well supported as we think.
Right.
If someone's got extensive disease, we know they're incurable, to put them through a PCI and the issues that might involve, I think we just need more data now. Maybe we need another study to sort of break the tie. But I definitely for limited disease, if they've had good response.
Sure.
I guess an extensive disease, maybe we need a better way to look for minimal residual disease.
Right, absolutely. So the most important thing is not whether PCI or not, but we need better drugs for extensive stage small cell lung cancer.
Absolutely.
And so a lot of things are happening, and I'm very, very excited to see the progress in non-small cell lung cancer. And the immunotherapy hopefully will benefit even patients with small cell lung cancer too.
Oh, absolutely. And I really want to congratulate you on this meeting. How many years have you done this now?
Quite a few years, and it's been going well, and we are very practical, we are community physician oriented, and we are having wonderful discussions, and this wouldn't be possible without faculty members like you. So Roy, I want to thank you once again for coming to the meeting. I want to thank you for participating in this expert panel discussion, and I hope we'll have many more issues to talk about in the coming years. Thank you.
To debate with you is an honor.
Thank you very much, and we thank you for participating in this, and we hope you will be able to, you'll have time to listen to the presentations that will be available online from this meeting. Thank you very much.